Hello everyone. In this module on miscellaneous GI topics, we shall be discussing some of the trending and important topics which students tend to sometimes neglect. But they are important, and the reason we have kept them separate is because many of these have some changes happening in due to one reason or the other, new research coming up or genetic basis changing or guideline getting changed. So that is why we have collected them separately for your benefit. So let us begin with celiac disease. The first topic is celiac disease. Celiac disease is also called as gluten sensitive enteropathy. Enteropathy means a disease of the intestine. So celiac disease in normal language, in common parlance, it is also called as wheat allergy. What exactly is celiac disease? First I'll define, then we'll talk about it. So the definition of celiac disease says it is a chronic systemic disease. So it is no longer considered to be only GI disease. We know that there can be systemic manifestations and associations as well. So it is a chronic systemic disease. However, the predominant features are malabsorption. So it is a chronic systemic disease characterized by malabsorption due to damage to intestinal mucosa by immune mechanisms in response to dietary gluten. Let us break down this description of celiac disease. See, what happens is whenever there is a patient who's predisposed to develop celiac disease, whenever the diet will have gluten in that, there will be immune response against that gluten. Now, since gluten and all these proteins are absorbed from the small intestine, so the body's immune response will be directed at the level of site of absorption, that is the small intestinal mucosa, mainly the duodenal and jejunal mucosa. So there will be inflammatory cells going and causing widespread destruction of the GI mucosa, which will produce malabsorption related to all the substances absorbed from there. That malabsorptive state, chronic inflammation seen in predisposed individuals, is called as celiac disease. The other name is gluten sensitive enteropathy. What are the things that you need to understand? First of all, it is not an acquired thing. Like if I am predisposed to develop celiac disease, only then I will develop. There are certain haplotypes, certain strong genetic associations which have been found to be associated, and certain populations which have a higher risk of developing celiac disease. Two people in the same family, one can have celiac disease, one cannot have celiac disease, depending upon what their genetic mechanism is, how their body is responding to gluten. And you need to understand that once you develop celiac disease, it is a lifelong thing. So it is not that you will give some immunosuppressant and the disease will go away. If you are allergic to something, you are allergic to that thing. That's it. It's as simple as that. And that is why gluten sensitive enteropathy, the disease was lesser known maybe 2-3 decades back. But as the prevalence is rising, as we become more aware of the prevalence of the disease, the risk factors, the presentations of the disease, we are finding more and more cases in an Indian setting, particularly the northern and western parts of the country where wheat based products are predominantly used. You find a relatively higher risk of celiac disease. And although disease can occur across any age, we find that children are predominantly affected. So what is the mechanism? How does the disease happen? So in bracket you can write down mechanism. It is mainly considered to be a T cell mediated inflammation. Now a lot of people have confusion regarding gluten, gliadin and glutenin. Remember that there is a protein called as gluten. It is a large protein present in the endosperm of wheat. Not only wheat, it is also present in barley, rye and sometimes in some varieties of oats. This gluten protein is composed of two smaller peptides. One is gliadin and second is glutenin. Glutenin is sulfur rich, disulfide bonds rich, whereas gliadin is sulfur poor. This gliadin and glutenin proteins are involved in giving that fluffiness when you heat wheat based products. So body actually develops these gliadin and glutenin in a normal bread or a normal cooked thing cannot be separated from each other. So when we say gluten sensitive enteropathy, it is basically the sensitivity to gliadin that is being talked about. Since gliadin does not exist independently, so the better term we use is gluten sensitive enteropathy. So the key thing to remember here is the inflammation, the antigen which is responsible for all this problem is gliadin, and gliadin is a part of gluten. You may get statements asking you which is a part of which. So gliadin के against सारा inflammation है. This is the culprit of this disease, and this culprit is a part of gluten, and so we call it as gluten sensitive enteropathy. Right? What are the risk factors? What are the conditions where this chances are more? Risk factors. So we'll give it the heading as risk factors and associations. First of all, risk factors, epidemiologically, it is found more frequently in northwestern parts of India, Punjab, Haryana, and Rajasthan belt, as well as some of the Mediterranean countries. Second risk factor is considered to be a genetic basis. We know that there is a genetic basis, and they show strong association with certain haplotypes. There are two HLA associations which are strongly seen. We have HLA DQ2 allele which is associated, and we have HLA DQ8 allele which is associated. Potential MCQ, HLA DQ2 allele shows the strongest association among any known factor. It shows the strongest association, potential MCQ. Then the disease is more common and is associated with syndromes. What are the syndromes associated with celiac disease? The syndromes include Down syndrome, Turner syndrome. The disease is more common in Williams syndrome. Then the disease is also associated with other autoimmune disorders like type 1 diabetes mellitus. It is associated with Addison's disease, etc. And finally, it is associated with a primary immunodeficiency state called as selective IgA deficiency. All these associations can be asked in exam. It is very, very important. And remember, there is a condition called as, I'm writing it separately, dermatitis herpetiformis. Dermatitis herpetiformis. It is a type of vesicobullous disorder. You will be reading about it in dermatology. Dermatitis herpetiformis is considered to be the skin localized version of celiac disease, of gluten sensitive diseases. So the vesicobullous disorder in dermatitis herpetiformis, it also responds to gluten-free diet. Although substances like dapsone are also found to be effective in them. So it is considered to be the part of the same spectrum. The antigen elicits a response not in the gut but in the skin. This is what, broadly speaking, roughly speaking, I can share. So you can consider dermatitis herpetiformis also to be a risk factor or association, but it is an independent disease by itself. So these are the risk factors and associations that you need to remember. Next, we come to the time of onset. When does the disease start? Most of the patients, the time of onset of the disease, the time of onset of features, predisposition pehle se hai, but the time of onset will be between 6 months to 2 years of age. Why? Because till first 6 months, the child is receiving exclusive breastfeed. So there is no response to gluten, no exposure to wheat. So the child is not getting any manifestation. 6 months of onwards, when your complementary feeds is started, then dietary gluten enters into the system, and in predisposed individuals, it starts producing inflammation. So over the next 1.5 years, the child tends to develop manifestation. This is the most common presentation. However, Harrison says, and what I have seen from my own practice, my own clinical experience, it can affect at any age also. He's a very senior colleague of mine, and he himself diagnosed as having celiac disease by getting all those tests done at the age of somewhere in the 30s. because he said that all through my life I had always been having low grade GI symptoms. I would always dismiss it off as some infection getting caught, or some irritable bowel syndrome like features. Eventually he went in for, he one day decided, why don't I get a celiac disease serology done. He went in for serology, then he got a biopsy done, and he had full blown features. So currently he diagnosed himself after doing his MD medicine as celiac disease. So the disease remains in the society, it remains hidden. Sometimes the features are not that prevalent. Although, from entrance point of view, remember, the childhood, early childhood, and late infancy is the time during which maximum children appear. So, what are the clinical features that we will see? The clinical features, first of all, the children will develop failure to thrive because malabsorption is happening, so failure to thrive features will be present. Secondly, these children will have GI symptoms in the form of malabsorptive diarrhea. So malabsorptive diarrhea, it produces bulky, foul-smelling, sticky stools called as steatorrhea. Constipation is also found to be common in them. This constipation is often associated with episodic abdominal pain, abdominal discomfort is there, and excess gas formation associated with borborygmy. What is borborygmy? That sometimes that sound is produced which is audible in the stomach, that kind of a sound. No, I'm not talking about farting, I'm talking about the sound which is produced during peristalsis. So they have extensive those sounds being produced. It is all a part of the chronic malabsorption happening in the child. Fourth, the children develop iron deficiency anemia, which is refractory to therapy, which is refractory to oral iron therapy, because oral iron is not getting absorbed. Then children will develop features of other multi-nutrient deficiencies. There will be rickets in the child. There will be features of vitamin A, vitamin K, and other micronutrient deficiencies. So these are the overall features which are seen in children with celiac disease. Now moving towards investigations. What are the options we have? First of all, we can go in for, we have a non-specific test which is now outdated, but some of the pediatricians still advise it. The non-specific test is called as stool for fat globules. For all practical purpose, we don't do it because we have better tests available, and stool for fat globule simply tells you there is steatorrhea, right? And sometimes steatorrhea may not be prominent enough to be picked up in the stool sample. So stool for fat globule is a very non-specific investigation, and as far as I remember myself, even in suspected celiac disease patients, I never advise stool for fat globules. This is what all the guidelines also say, that it is an obsolete test. But from entrance point of view, you should remember that there is a non-specific test which can be done. Then other than that, we go in for serology. Serology is very important. In serology, we check for the autoantibodies formed in response to gluten. Now, serology checks for, we always go in for immunoglobulin A antibodies. Remember that this is one condition where IgA antibodies are superior to IgM and IgG. This is the principle that you must remember. For serology, in serology, the screening test of choice is a test called as IgA anti-tissue transglutaminase. Transglutaminase is an associated antigen in the gluten. So there will be antibodies forming against as well. So IgA anti-tissue transglutaminase, it is written as IgA anti-TTG. IgA anti-TTG is considered to be the screening test of choice. It is commercially available at all major centers and medical colleges. It has a sensitivity of 99 to 100%. It is the most sensitive test. It has equal specificity as the second test which we perform. Another test, important test that we do, but not as a screening test, is IgA anti-endomysial antibody test. These are the two antibodies which are elevated in all patients of celiac disease. The exception being those with IgA deficiency. There you will have to depend upon biopsy. You cannot depend upon these serological tests, or you will have to go in for IgG based tests. So IgA anti-TTG and IgA EMA. Both are very sensitive and very specific, but IgA anti-TTG is cheaper, easier to do, and has 0.5% more sensitivity, and so it is considered to be the screening test of choice. So these are the two tests that we perform. Other than that, we go in for HLA typing, where we look for DQ2 and DQ8 allele, and finally we have upper GI endoscopy, UGI इसे लिखते हैं, upper GI endoscopy and biopsy, which is considered to be the gold standard investigation. It is the gold standard investigation. When you do upper GI endoscopy, you find that duodenal and jejunal mucosa, duodenal and proximal jejunal mucosa, that has been smoothened, overly smoothened mucosa because of atrophy. When you take biopsy from that sample, that biopsy it undergoes histopathological examination. Details of the biopsy are important for your exam. So we are discussing a high yield thing here. What are the biopsy findings? Biopsy findings in celiac disease. On histopathological examination, you find that first of all, these children have subtotal to total villus atrophy, right? Second, there is increased in the number and depth as well as branching of crypts of Lieberkühn. If you remember your histology, then crypts of Lieberkühn are present in the small intestine. And third, there is increased in the level of intraepithelial lymphocyte. So lymphocytic proliferation is seen in the gut mucosal epithelium. It is written as IEL, intraepithelial lymphocytes. And fourth, crypt to villus ratio is increased. Some books write it as villus to crypt ratio, then it will be decreased because villus chota ho gaya, crypt is larger in size. So crypt, if it is in the numerator and villus is in the denominator, that ratio will be elevated. So these are the four classic findings you find in patients with celiac disease. All four have been asked as MCQ point. All of the following are seen in celiac disease on histopathology, except this is how the questions are asked in exam. So I have to just show you, I'll show you histological picture also, but here imagine that this is the small intestinal mucosa, right? These are the villi. In between you will have a crypt of Lieberkühn and there will be occasional lymphocytes being present, right? When patients of celiac disease, in full-blown celiac disease, gluten-sensitive enteropathy develops, there is subtotal to total villus atrophy. So there will be, the mucosa will be like this. So subtotal to total villus atrophy, and the number of crypts of Lieberkühn will be larger and more numerous in size. And it will be filled with intraepithelial lymphocytes like this. So large number of these cells, this infiltration will be seen in these patients. So this is what we mean by all these findings. Now, extra edge thing. How do you do grading of histopathology in celiac disease? I'm putting a star, MCQ point. In celiac disease, histological grading is done by a system called as Marsh grading. Marsh was the person who gave these grades. According to Marsh grading, grade 0 is a normal, non-celiac patient, grade 1 is the mildest form, and grade 4 is the severest form where the complete architecture has gone, right? So Marsh grading, broadly speaking, you can just add it to your notes. On one side you would write the Marsh grade, other side you would write the histological feature. These are hot important things. You'll not find them easily given in OP-GHI. They are a part of the standard your management, and in an integrated clinical question there is a good likelihood of being asked in the exam. So grade 0 is a normal histology. So no celiac disease is present, right? Grade 1, there will be increased in the number of intraepithelial lymphocytes. Kitna? equal to or more than 20 cells, 20 lymphocytes per 100 enterocytes. For every 100 enterocytes, there should be equal to or more than 20 cells. That is called as grade 1. In grade 2, there will be, the upper grade will be there. Additionally, there will be proliferation of crypts of Lieberkühn. Then we have grade 3. Grade 3, villus atrophy will start, right? So grade 3 is divided into 3A and 3B. 3A, there will be partial villus atrophy. Other features are there. Then 3B, there will be subtotal villus atrophy. And grade 3C, there will be total villus atrophy. And finally, we have grade 4, where there is complete disruption of the mucosal architecture, the most severe form. So this is known as the Marsh grading. Let us have a look at how Marsh grading actually looks like. So on this slide, you can see grade 0, this is the normal histology. Grade 1, only there is increase in the number of intraepithelial lymphocytes which are happening, right? Small, all these cells, they are lymphocytes only. Then in grade 2, you have proliferation of the crypts of Lieberkühn. This proliferation has started happening. Then in grade 3A, there will be subtotal villus atrophy. Grade 3B, there is partial villus atrophy here, 3A. Here there is subtotal villus atrophy. And if you see in 3C, all the villi are totally gone, so total villus atrophy is seen. And grade 4 is not mentioned because there it will be indistinguishable, because the entire disruption of the architecture will happen. So this is how Marsh staging. Don't worry, you'll not be getting a histopathological slide. Just the comparison thing is what I need you to understand and remember. Moving towards the diagnostic criteria. For the purpose of diagnosis, there is a latest change, what we called as Nass-Fagan criteria. Nass-Fagan criteria 2020. It came in 2020 and is supposed to be valid from 2021. So you can expect questions to be asked from this. Nass-Fagan criteria. Nass-Fagan ke full form nobody is going to ask, but if you want to know, North American Society for Pediatric Gastroenterology, Hematology and Nutrition. So it's just a big pan North Indian community. So this criteria says that whenever you have clinical suspicion of celiac disease, it is a very complicated flowchart. I have made it a bit simpler for you to understand. So whenever there is clinical suspicion of celiac disease, you will always perform investigation. Which investigation? You will perform two tests. You will do TTG, IgA anti-TTG, but because selective IgA deficiency can also be there, so you will do total IgA as well. So any patient with clinical suspicion, you will perform IgA anti-TTG plus total serum IgA. So both tests will be done. They will be performed. Now there will be two possibilities. Either anti-TTG, IgA anti-TTG is negative, and second possibility, IgA anti-TTG is positive. It is raised, it is elevated. Okay. Now, if IgA anti-TTG is negative, you will look for the total IgA. If the total IgA, serum IgA which we did, is normal and TTG is negative, you will say there is no celiac disease. Right? In case the total serum IgA is low, then there is a possibility that it is falsely negative, that IgA TTG which we have done. So you will perform a test called as IgG, not IgA, IgG anti-TTG and IgG anti-endomysial antibody, and then you will decide. Right? In case IgA anti-TTG is positive, So then we have to see how much is the titer. If it is not much elevated, like the value is less than 10 times the upper normal limit, there is a normal value age defined, right? So if it is less than 10 times the upper normal limit, you need to confirm by a histopathological examination. So you will do upper GI endoscopy along with biopsy, right? If it is equal to or more than 10 times the upper normal limit, in that scenario, you will perform IgA anti-endomysial antibody. So we are trying not to do biopsy. Biopsy is an invasive procedure. Endoscopy is not available at all the places. So you will do IgA anti-EMA antibody test. If it is negative, you will do upper GI endoscopy with biopsy. And if IgA anti-EMA is also positive, both of them are elevated, you will say it is confirmed celiac disease. Confirmed celiac disease, and there is no need for biopsy. Here also, if they are found to be elevated, if they are positive, you will confirm the diagnosis by doing upper GI endoscopy with biopsy. So this flow chart looks very, very tricky. It looks very overwhelming, but it is the one which is recommended, and it is the one which can be asked in your entrance exam. This is what we actually normally do these days. So I've tried to make it as simple as possible. Clinical scenarios on this for practice we'll be putting in the question bank of ours. So after this, finally we come to the treatment of celiac disease. Talking about treatment of celiac disease, the only treatment therapy is gluten-free diet, which is given lifelong. And the patient should avoid any substance having wheat, barley, rye, and even oats, because oats can be contaminated with gluten during processing. And what are safe cereals? Rice and maize are considered to be safe cereals. What is the risk if you don't correct this condition and you don't put the patient on gluten-free diet? Other than malabsorptive symptoms, there is a long-term, in a chronic disease, untreated disease, there is a slightly increased risk of developing GIT lymphomas, and they are also considered to be the cause of death. GI lymphomas mainly are of the non-Hodgkin lymphoma variety, derived from the mucosa associated lymphoid tissue, MALT. So वहां से arise करता है non-Hodgkin lymphomas. They are the cause of death. So when you counsel the parents, when you counsel the patients, when you tell them you have to leave roti, leave bread, leave cake lifelong, they may not have eaten cake for last 10 years, but when you say cake nahi khana hai, so it's a human psychology. They will say, oh, how would I live, and is there a way out? They will go in for all these Ayurvedic homeopathic preparations, that they will go in for Chinese acupressure and acupuncture techniques, and eventually they will roam around 3 or 4 doctors and eventually come back to you saying nothing is happening, symptoms are still improving. Then you counsel them that there are certain communities who don't eat wheat, and you can lead an absolutely normal life without wheat. It's just that you, since birth you have been eating wheat, since childhood you have been eating wheat, so it's a psychological thing. Gradually move away. If you don't move away, there is a more risk, slightly more risk. Not everybody develops, but slightly more risk of developing lymphoma. The moment people hear of lymphoma, everyone falls into place. But it requires a lot of good counseling and proper support. A lot of medical colleges, including PGI Chandigarh, have dedicated celiac disease clinics twice a week in pediatrics as well as in the adult gastroenterology. So this is regarding gluten sensitive enteropathy. The next small topic we'll be discussing is cow's milk protein allergy. Again, fairly common, but not properly read or not properly understood. In short, it is written as CMPA, cow's milk protein allergy. First of all, it is considered to be the most common food allergy in top fed children. So it is the most common food allergy in top-fed children in the first 6 months if they are being given formula feed or cow's milk based products. However, breast milk fed babies can also sometimes develop allergy whenever there is some antigen related to cow's milk. It gets secreted in the breast milk from the mother, although that is a very rare thing to happen. So, most common food allergy in top fed children. It is a fairly common disease. It comprises almost 13% of all chronic malabsorption cases below 2 years of age in Indian population. So it is a fairly common condition. What exactly happens? Now, whenever cows milk protein, these children again, they don't develop due to a reason. You are allergic to something or you are not. Right? Like I am allergic to prawn. So I am allergic to prawn means I am allergic to prawn. Uska koi reason nahi hai why am I allergic to prawn. So similarly, children who are allergic to milk protein allergy, they are allergic to this. So there are two types of reactions which are seen. There are two types of CMPAs which are seen. First variety is the IgE mediated. IgE mediated is also called as the immediate type. And second is your delayed or T cell mediated. T cell mediated is found to be, it is also called as delayed variety. Overall, T cell mediated is found to be more common in India, whereas IgE mediated is more common in the Western population, especially United States of America. But overall, the incidence of CMPA is more in the developing countries, and so T cell mediated is the one which is found to be more common. In IgA mediated or immediate sensitivity, whenever the child will consume milk, there will be development of shock-like state, there will be urticaria, there will be vomiting, and there will be extensive sweating. That acute state will be this variety. T cell mediated will have an indolent course. So whenever the child consumes milk, there will be an indolent form or progressive form of illness, mainly involving the GI symptoms. The most common GI symptom is diarrhea. They tend to develop diarrhea with blood and mucus. So it looks like dysentery. They will also have vomiting. They will have abdominal pain. And sometimes even hematemesis can also develop. Hematemesis can also be seen. Remember that almost 50 to 60% are also found to have skin allergies like eczema, atopic dermatitis, eczema will be present. And almost 20 to 30% will have respiratory allergies, respiratory atopy, for example, asthma. So they are all a part of the same family, or allergic rhinitis. So you need a high degree of suspicion to identify. When you do investigations, you will find that all of these children, they have microcytic hypochromic anemia, which is due to iron deficiency. These children will have low total serum protein level, so hypoproteinemia will be seen. They will have increased peripheral blood eosinophils, so eosinophilia will be seen. When you do sigmoidoscopy, you will find aphthous ulcers to be present, and when you do rectal biopsy, you will find small abscesses filled with eosinophils. So there is a eosinophilic infiltrate, which is very unusual. Gold standard of investigation is always if you can't make the diagnosis, gold standard is always a challenge test. In challenge test, what we do? We stop milk for 48 hours. There is resolution in symptoms. Then you again give milk. Within 48 hours, there is again recurrence of the symptoms. Then you again stop it, the symptoms go away. That is called as a challenge test. It is seldom done these days. So what is the therapy? There is no other therapy. Eliminate milk from the diet. Although the name is said to be cow's milk protein allergy, but buffalo milk and other animal milk are also found to be, most of them are found to be allergic to those milks as well. It is just that the name is cow's milk protein allergy. So eliminate milk from the diet. What are the alternatives to milk that you can use? The alternatives to milk can include soya-based products. You can use extensive hydrolysate formulas, and you can use amino acid based preparations. But soya milk is avoided below 6 months of age, and soya allergy is also common, unfortunately, in some of these individuals, and so you cannot use them. Extensive hydrolysate formulas and amino acid based preparations are the ones which are actually used, but they are costly. So but the good thing about this condition is that both OP Ghai as well as Nelson, they both agree that children outgrow this. 50% of children outgrow means they stop getting allergy to this. They outgrow this illness by 1 year of age, and more than 95% they outgrow this illness by 5 years of age. So this finishes the discussion of cow's milk protein allergy, a small topic but important. And finally we come to discussion of Hirschsprung's disease. Let us briefly discuss Hirschsprung's disease. Hirschsprung's disease is also called as congenital aganglionic megacolon. Hirschsprung disease is considered to be, now there are a lot of new, important, exciting things. Not new, but they are a part of the latest research which has gone on. Hirschsprung's disease is considered to be a type of neural crest defect. These defects are also called as neurocrystopathies. So it belongs to a class known as neurocrystopathy. What are the strong associations of Hirschsprung's disease? Hirschsprung's disease sometimes shows a positive family history. It tends to run in the family. Secondly, there is our increased association with Down syndrome. Third, Hirschsprung's disease has a strong association with neuroblastoma. And the most common gene associated with Hirschsprung's disease is a RET gene. It is a proto-oncogene. Potential MCQ. RET gene is the most common gene associated with Hirschsprung's disease. So what exactly is the defect? There is an absence of ganglion cells in the submucosal and myenteric plexus in the gut. You know that these submucosal cells, these ganglion cells present in the Ayurbex plexus and Meissner's plexus, they are responsible for generation of peristalsis. So mostly it affects, although it can involve any segment from mouth to anus, this is what the books say, but mostly it involves the area distal to splenic flexure of colon. So rectosigmoid region and descending colon is the area which is mostly affected. In that region, wherever there will be a segment where the so-called classic disease, there will be a segment where ganglion cells will be absent. So what will happen? Peristalsis will come, fecal material will come, then it will stop at this point. Right? It will stop at this point and it will cause, when you do enema, there will be dilatation of this. It will be loaded with fecus. The remaining part, the actual affected part, peristalsis is not happening. So that will be tapered and constricted. Then again, normal caliber will be seen. So that constricted part is the one where disease actually is present. And that is what the manifestation is. These children will develop features of constipation. Early in neonatal life, they will have failure to pass meconium, and they will have acute episodes where intestinal obstruction-like features can be seen. So what is the problem in Hirschsprung disease? What is the cause of Hirschsprung disease? Absence of ganglion cells in submucosal and myenteric plexus of the gut, leading to loss of peristalsis in the affected segment. What is the most common site affected? Most common site affected, most cases they occur distal to splenic flexure of colon. I hope you know the basic anatomy. Splenic flexure of colon. In that also, it is the rectosigmoid junction and descending colon, which are mostly affected. If you have to choose one, rectosigmoid will be the better answer. What are the clinical features? In the neonatal period, they can present with delayed passage of meconium. So there will be delayed passage of meconium in the newborns. In the older children, later life, beyond neonatal period, you will find constipation. The child will be passing stool after a gap of 5, 7, 10 days. That kind of a constipation. They will develop abdominal distension, and there can be acute episodes of obstruction like features, which can even perforate as a complication. So what are the investigations that you will do? When you do per rectal examination, you will find that there is a empty rectum, but on withdrawal of fingers, a gush of stool, a gush of semi-solid stool will come out. It is just a physical finding which we sometimes see in the common variety. It may be missed in some of the other variants in case that's affected, rectosigmoid part is not affected. So we need to perform investigations. In investigation, we perform barium enema. What you will find on barium enema? On barium enema, the following picture will be seen. There will be a dilated segment followed by a transitional zone followed by a constricted area. This constricted zone is the part where ganglion cells are absent. Right? Let us look at the picture. Let us look at the classic visual. Can be asked in exam. Look at this visual. After doing barium enema, you can find that this is the dilated segment. This is your transitional zone, and then this is your constricted part. So this constricted part, this is the one which is affected in these. So there will be, as I just said, there will be a dilated segment coming, then it will taper, and then it will become constricted like this. So this part where tapering begins, this is the dilated segment, this is your transitional zone, and this is the constricted part. It is the constricted part which is found to be affected. And if you have to do biopsy, this is the part from where you should be taking biopsy. Other than this, if you perform anorectal manometry, you will find that there is failure of relaxation of internal anal sphincter. Internal anal sphincter. Gold standard is always biopsy from the affected segment, from that constricted region. When you do biopsy, you will find that there is absence of ganglion cells. When you do histopathology, ganglion cells will be absent. There will be increased staining for a marker called as acetylcholinesterase. So ACHE staining will be increased. And thirdly, there will be hypertrophied nerve fibers which will be present. Hypertrophied nerve fibers will be present on biopsy. Treatment of choice, it is always surgery. Various types of procedures including pull-through surgery, push-up surgery, followed by anastomosis, they have been described. Two of the common surgical procedures include Swenson's procedure and Duhamel procedure. The names are, you can just remember if they can ask you. Swenson procedure done for this, Duhamel procedure done for this. These days, laparoscopic surgeries are very frequently done in the non-complicated areas. And the details of surgery we are not discussing because this is pediatrics. But we have discussed the topic in a way that it has covered some of the approach-based things related to other subjects as well.